motility disorder starts with primary versus secondary, and if you see the origin of pathology, now this is going to decide a lot of things. So origin of pathology at the level of esophagus, then that is a primary, and if the origin of pathology is systemic, then that is known as what kind of, it is classically known as a secondary. So because it may be associated with scleroderma, it may be associated with diabetes mellitus. So what are the associations in secondary? So you can understand Trypanosoma cruzi, it causes Chagas disease. Yes, it could be diabetes mellitus, which is a well known, you can say, entity. It could be associated with scleroderma. It could be associated with variety of condition which are known as collagen vascular disorders. So collagen vascular disorders, scleroderma, diabetes mellitus, Trypanosoma cruzi, etc., etc. It could be idiopathic, no one knows. Yeah. So these are the classic entities which we actually call as secondary causes of secondary esophageal motility disorder. That is not that important. The most important aspect is the primary. When we talk about primary and the origin is at the level of esophagus, so the primary esophageal motility disorders, PEMDs, they are of two special types. And what are the two types? Let us understand. The first is, let us just update this. Yeah, okay. So the first is, we have the spastic variety and another one is the achalasia. So broader, you can say, in broader terms, if you talk about, it could be spastic versus achalasia. Now when we talk about spastic versus achalasia cardia, itself is a entity. So overall it is achalasia which is the most common type, but let us understand the spastic type. Spastic types are the varieties which are associated with pain because of the immature contractions or the spasm. So this is again DES. What is DES? Everyone knows it as diffuse esophageal spasm. But do you know, as per the newer nomenclature, this is known as distal esophageal spasm. It has been seen that majority of the conditions, it is the distal part of the esophagus. So nowadays we also call it distal esophageal spasm. We shall see it later. The second is, we have nutcracker esophagus, or we also call it hypercontractile esophagus. So what is hypercontractile esophagus, or the another name for this is a nutcracker esophagus. And the third variety that we have is hypertensive LES. Now do you know, each variety is unique and that is why they are segregated. The last is, so we have seen the DES, we have seen hypercontractile esophagus or a jackhammer esophagus or a nutcracker esophagus, whatever you say. Hypertensive LES, and we have inefficient esophageal motility disorder, IEMD. So we shall be discussing all of them. We shall be discussing each and everything related to spastic. We shall be also discussing achalasias. But now the problem is how to differentiate. So we often mug up the pressure in DES is between 180 to 400 mmHg. In, you can say, in the achalasia it is low. Lot of things are there, but let me make it very clear. So whenever we have a patient of esophageal motility disorder, the first thing is to segregate it between the secondary versus primary. When we talk about the primary, we need to segregate it between the spastic and the achalasia. Now when we talk about the classical, you can say, esophageal motility, it has to be evaluated with the manometry. Now here a lot of things will come. So when we talk about the manometry, you have to understand that manometry is the gold standard investigation. Without manometry, you are blind. You cannot differentiate between anything. You cannot differentiate whether it is DES versus achalasia versus whatever it is like, because all of them, yep. All these classes will be uploaded, don't worry. So Hemant, all these classes will be uploaded, so don't all of them will be there for, you can say, later view also. So automatically the live classes gets recorded. So whenever we talk about the manometry, what are the things that we need to understand? And 90% of us forget this. We mug up, okay, manometry is the gold standard, and after that we don't know how to approach them. Now today we shall understand each and everything in detail. Whenever we talk about the manometry, we aim to evaluate what? So we aim to evaluate following things. And what are they? The tone as well as the peristalsis. So if we want to check the tone as well as the peristalsis, what are the parameters, what are the medical terms that we need to understand if you want to see the peristalsis? First thing that we need to understand is the manometry, the manometric parameters. So the manometry includes following things. What are the things that it includes? You must have heard of something which is known as CDP. Now this is very interesting. Why? Because when you read, you can say textbooks, basic textbooks like Bailey and Love, they might have mentioned about few things, or even Sebastian and Shorts, they have mentioned, but it's too much confusing. So what are the parameters that we have? We have CDP. This is known as contractile deceleration point. So I'll be using the shorthands after this. So contractile deceleration point, this is first entity. What is another? We have something which is known as DL. I'll explain each and everything. So DL stands for distal latency. So DL stands for distal latency. So we have contractile deceleration point, we have distal latency. The third is IRP. What is IRP? This is like surgery, Dada, you must see we have an international residency program, that is not this. So IRP is integrated resting pressure. All these things are gold standard parameters. If you understand, you will never get confused. You can say in a fraction of a second you can understand what it is, and thus you can decide whether we need to go for endoscopic management or surgical management. So integrated resting, you can say, pressure. And fourth is DCI. What is DCI? It is distal contractile integral. So if you want to actually understand what esophageal motility disorder we are dealing with, you need to understand these parameters. Now let us start. There are a lot of, you can say, confusing facts about this, but I shall try to explain it to you in a very simple fashion. So when we talk about CDP, as we know that it is contractile deceleration points. So as the word says, deceleration. So whenever the esophagus contracts, there will be a point where it has to stop. So the pressure wave front will move forward from the upper esophagus up to the level of LES. By the time, so you are running down the esophagus, you're going up to the level of esophagus, you have to brake now. And that is the point that at which a sudden brake is applied by the esophagus, that okay, this is the limit. And therefore on the manometry, if you see the isobaric contour, so you'll get to see a kink, and after that, yes, the pressure flattens. So this is very important. It is the point of, you can say, deceleration, or you can say the kink. So it is the point of deceleration or kink for pressure front of esophagus of contraction. So the contraction is moving forward and it has to come down. So do you know this CDP is very important, and roughly it is 2 to 3 centimeter above the LES, lower esophageal sphincter, where you will actually see the kink. So this is the point, and this is known as contractile deceleration point. Is this clear to everyone or no? The second thing is the second thing is DL. So what is DL? It is distal latency. Basically, if you want to understand the timing of peristalsis, this is really very important. So I hope you can understand that for peristalsis to happen, you have to have a wave of contraction, relaxation. Contraction, relaxation. This is important. So this timing of synchronology between the contraction and relaxation is important. So what happens? So suppose I am having water. Whenever I swallow, there will be relaxation of the upper esophageal sphincter so that the food or the bolus goes down, and it goes down, and then it is going to reach the CDP. This is very important. Now the next wave will again start. So this is where the contraction and relaxation is happening. So the time between the upper esophageal relaxation and the CDP, this is what is known as distal latency, or you can say the gap between this. So the relaxation of the upper esophageal sphincter and the CDP. Because if the CDP is less, that means the contractions are happening too rapid, and this is where the normal tone is altered and you get to see the spasm, and this is what we see in, you can say, in the diffuse esophageal spasm or distal esophageal spasm. So timing of peristalsis is decided by distal latency, and it is the gap between upper esophageal you can say relaxation and CD and the contractile deceleration point. So basically the next wave starts. Remember, important, normal distal latency is more than 4.5. So if it is more than 4.5 seconds, then that is normal. But if a second wave appear in less than 4.5 seconds, this is actually where the spasm starts. So less than 4.5 seconds, this is abnormal, and remember this is associated with the spasm. So we have got to understand the timing, we have got to understand the natural break. The next is IRP. What is IRP? We have seen integrated relaxation pressure. Now again a very interesting phenomena. Now it is the minimum pressure. So this is the minimum pressure recorded. So minimum pressure at the level of LES across 4 seconds, over 10-second window. Is this clear? So you can understand, normally for a bolus to go down, taking 25 to 27 centimeter as the length of the, you can say, esophagus, and the rate of propulsion to be 3 to 4 centimeter per second. So roughly 8 to 9 seconds or maximum 10 seconds is the time for the, you can say, bolus to reach the LES. So across the 4-second window, over 10 seconds of swallow. So usually the swallow from up to down, it takes 10 seconds, and during this 10 seconds, the minimum recorded pressure, this is what is known as IRP. Now why is this technically very important? Remember, IRP more than 15 mmHg. Now this is very interesting. IRP more than 15 mmHg is indicative of gastroesophageal obstruction. Is this clear or no? So usually if you see in cases of achalasia, we get to see IRP more than, you can say, more than 15. That is indicative of the obstruction at the level of the GE junction. Now dear students, let us understand the last term, and what is that? That is known as DCI. So what do we mean by DCI? And this is known as distal, contractile, this is known as distal contractile integral. Very interesting. What is the concept of distal contractile integral? Very important thing. It is nothing but the volume. It is the volume of contraction. Now this is very important. So what is volume of contraction? Or you can say, we have one more word, it is the strength of contraction. Dear students, I might be wasting some time in this, but if you don't understand them, you will be always flat. So what is the concept of this DCI, distal contractile integration? If you see the esophageal integrity, contraction integrity, The esophagus during contraction maintains a tone of 20 mmHg. That is why we call it 20 mmHg isobaric contour. So throughout the, you can say, esophagus, we get a 20 mmHg pressure. Now understand, this is very important. Pressure, this is defined as the pressure, or you can say this is 20 mmHg. This is the baseline, you can say this is the baseline pressure that we have throughout the esophagus. Now there is something which is known as transition zone, and from transition zone up to the level of lower esophageal sphincter. So whenever we talk about transition zone to lower esophageal sphincter, there might be an excess increase in the strength to push the food forward into the stomach. So there we measure the DCI, distal contractile integral, and it is defined as amplitude across that domain. So amplitude of contraction into the length of contraction into the time of contraction, and that is why it is donated, it is written in terms of mmHg second centimeter. Is this clear to everyone? This is really very interesting phenomena. Now normally here we record the pressure, so the amplitude is recorded above the 20 mmHg. So if it is above 20 mmHg, you are going to record it, multiply by the segment length, multiplied by the, you can say, distance. Normally when we talk about, it is more than 450 to 8000 mmHg second centimeter. Is this clear or no? This is normal. More than 8000, this is important. This is associated with hypercontractile esophagus. So dear students, if you get to see a DCI more than 3000, more than 8000, that means you are dealing with a hypercontractile esophagus, which is also known as a jackhammer esophagus, because this is not going to go to that value in any other case. So merely if you see dysphagia, if you see chest pain, this is not the way to diagnose, you can say, esophageal motility disorder. The esophageal motility disorder is purely a diagnosis of manometry. If you don't know the four important terms, you cannot do anything in residency, even if you are going for the super specialty exams, or if you are doing endoscopy, or if you are doing HRM at your hospital, you will not be able to do anything. So remember four important points: CDP, DL, IRP and DCI. CDP I have told you, point of deceleration, the point at which the brake is applied at the level of esophagus. So on HRM you will see a kink, and usually it is 2 to 3 centimeter above the G junction. This is the point where the esophageal forward propulsion slows down. Then there is something which is known as DL. So gap between the two, you can say, peristaltic waves, basically in a layman's language. And if you see, this is the gap between the upper esophageal relaxation and the contraction deceleration point. Usually it should be less than it should be more than 4.5 seconds, and less than 4.5 seconds indicates premature contraction, and this is what is diagnostic of DES. So merely pressure is not important, amplitude is not important. Then we have IRP, integrated relaxation pressure. During the transit of bolus, it takes usually 10 seconds for a food bolus to go from upper to lower esophageal sphincter. So the lowest pressure recorded during a 4-second window, this is what is IRP, and if it is more than 15, it indicates what? The the esophagogastric junction obstruction or GE junction obstruction. Now let us understand, we have seen the strength of esophageal contraction is seen with the help of DCI, that is distal contractile integral, which is nothing but a multiplication of the amplitude by length by time, and usually it is 450 to 800. Now why I am talking about this? Now this is important. So if it is more than 8000 mmHg per second per centimeter, this is actually diagnostic of hypercontractile. Value less than 100 mmHg second centimeter, this is actually diagnostic of peristalsis. And remember, value less than 450, value more less than 450 up to 100, This is actually diagnostic of in esophageal motility disorders. Is that clear or no? So this is the phase where the things are totally going to change, because if you don't understand this thing, you'll never be able to come to conclusion of anything. Now, when I was teaching you DCI, I told you that there is something which is known as 20 mm Hg baseline contour. So there is something which is known as fragmented peristaltic disorders. What is fragmented peristalsis? Now this is a diagnosis of exclusion. If you are not getting anything, so everything is between the normal range, DCI is normal, the integrated relaxation pressure is normal, but still the patient is having dysphagia, this is something which is known as fragmented peristalsis disorder. Now how to see? Normally what happens when we measure the pressure across the peristaltic wave of the esophagus, it should be 20 mm Hg. Now, there may be some points where the pressure might be lower than this. Now, this is the place where the peristaltic activity has fragmented. Usually, if it is 2 to 3 centimeter, this is physiological. But if this gap of peristaltic pressure is more than 5 centimeter, this is diagnostic of an abnormal contractile integral, and this is how you diagnose the fragmented peristaltic disorders. So let us talk about that before we move forward and go to the further evaluation of achalasia and everything. So there is something which is known as contractile integral. Normally in routine sessions, I don't teach into UG students, I don't teach all these manometric findings, because they'll run away after understanding this. Okay, surgery is really very tough, but you need to understand them for your residency, for each and every purpose. So what is contractile integral? The pan-esophageal, you can say the isobaric pressure contour, if you talk about 20 mm Hg pressure contour, this is very important. So this is isobaric contour of the esophagus. Break more than 5 centimeter segments. So break segments more than, you can say, 5 centimeter with pressure less than 20 mm Hg. This is actually diagnostic of fragmented peristalsis. Is this clear or no? So yes, there is something which is known as fragmented peristalsis or peristaltic disorder. Now let us summarize each and everything in nutshell. So whenever we talk about achalasia, what is going to happen in achalasia? You know that achalasia is equal to A peristalsis. We'll again come back to these to this in detail. But remember, achalasia is equal to A peristalsis, and along with that, so therefore you get to see low DCI. So low DCI, one thing. Along with that, hypertensive LES, increased pressure at the level of lower esophageal sphincter, and therefore high, we get to see IRP. This is classic A peristalsis with the high IRP. This is what is diagnostic of a classical achalasia. Remember, there is something which is known as type 1 achalasia, type 2 achalasia, and type 3 achalasia. So this is a classic achalasia. Now there is something which is known as vigorous achalasia. Now if you see vigorous achalasia, it is a condition where you get to see peristalsis. But the problem is the peristaltic waves are mirrored simultaneous contractions, and therefore the peristalsis is there. So the pressure will be there. But the problem is, normally what happens? A peristaltic wave to be progressive, on one side if it is elevated, another side it has to depress. If this is the crest, this is the trough. If this is the depression, here is the elevation, then only the food bolus will pass. If you see here, both the sides of the esophagus, if we divide the esophagus into two and put a mirror in between, aren't they mirror images of each other? Because if it is contracting at this point, another point is also there. So technically, if you see here, the DCI is more than 450, point number 1. So one thing is there because peristalsis is present. So in vigorous achalasia, you have increased amplitude. So yes, there may be high DCI. So increased amplitude, simultaneous contractions. So since the contractions are simultaneous, it is not going. And why it is vigorous achalasia or spasmodic with the distal latency less than 4.5 seconds, and therefore you also get to see the spasm. So this is very important way to understand what type of achalasia is this on the basis of simply manometry. So IRP is important, everything is important. So IRP is elevated, along with that the distal latency is less than 4.5 and DCI is more than 450. Next is let us talk about diffuse esophageal spasm. So this is also known as distal esophageal spasm. So distal esophageal spasm or diffuse esophageal spasm, here we get to see normal peristalsis, but where the problem is, here the DCI, distal contractile integral, is more than 450. Yes, this is standard. So more than 450 it is there, 450 mmHg second centimeter, but less than 8,000, because you know if it is more than 8,000 the problem will start. But then why it is painful? The answer to this is intermittent premature contraction seen in more than 20% of the wet swallows. So whenever we do manometry, we have to ask the patient to swallow. So once you swallow, the study is taken. So in more than 20%, suppose we generally allow 30 swallows. So in 30 swallows, it has been seen if it in more than 6 swallows, the distal latency is found to be less than, you can say, 4.5 second. This is what is a classical DES, diffuse esophageal spasm. I'll again summarize them clinically also. Next is we have hypercontractile esophagus or a nutcracker esophagus. Now when we talk about nutcracker esophagus, we need to understand it's a more powerful esophagus. Everything is okay, but the only problem is the strength is. So integrated relaxation pressure is absolutely normal, so there is no problem with the lower esophageal sphincter. Along with that, distal latency is more than 4.5 seconds, so that is also absolutely normal. So there is no problem with the timing of the peristalsis. The only problem is increase distal contractile esophagus, you can say integral, that is more than 8,000, you can say mmHg second centimeters. So next time you come across the manometric findings, you should not get stuck with what is what type of, you can say, what is what type of esophageal motility disorders. Let us quickly summarize each and everything, and let us discuss the concept of the spastic in nutshell. So again I will correlate them. Remember, when we talk about the spastic, the classical presentation, spastic esophageal motility disorder, the first thing that we have is dysphagia. So yes, everyone knows dysphagia is there. Along with that, there is chest pain. So dysphagia with chest pain is a classical presentation in case of spastic disorder. Now when we are talking about the spastic disorder, as you have seen, we have discussed already about all the manometric findings, what is the DCI, what is DCL, everything we have discussed. Yeah. Now let us clinically see how the presentation makes. So merely by saying dysphagia plus chest pain, we cannot decide whether it is the DES. What is DES? Diffuse esophageal spasm, or I have already told you that nowadays we also call it distal esophageal spasm. Now what is the problem? The problem here is it is normal, you can say it is a normal normal esophagus. There is no specific pathology, normal esophagus with premature intermittent high, with premature intermittent, you can say contractions of high amplitude, So if you classically see them, this is very interesting. On manometry, we allow the patient to swallow, and when he is swallowing, it has been seen that in more than 20% of the cases, the peristalsis, which should be like this, it becomes erratic. There are premature contraction causing spasm. So this is what is the classical difference between a nutcracker and a normal esophagus. So there is no problem except the premature contractions. So premature, intermittent, high amplitude, you can say waves are there, or peristalsis is there. Now just let us see more important things. Now you will say on barium. So barium is not a routine investigation to be done here, but still we do it. So on barium we get to see a classical corkscrew esophagus. And why we get to see corkscrew esophagus? Because it starts, the contractions are more prominent at the level of the lower esophageal, you can say, zone of the esophagus. So we get to see corkscrew esophagus, classical corkscrew esophagus, or one more thing that we can get is, so we get to see corkscrew esophagus, or you can say we also call it pseudo diverticula. Why we call it pseudo diverticulae? Try to understand. Very simple, very simple. So let us see this. If you see this esophagus, it seems that there is outpouching on these sides, and actually this is not outpouching, it is the normal esophagus, and in between them you get to see contracted part that is resembling a corkscrew or a classical, so a corkscrew or a classical pseudo-diverticulae. However, this is not the way to diagnose a DES. So what is DES? DES is a condition where we get to see a normal body of esophagus with abnormal peristalsis. So you get to see intermittent high amplitude peristalsis. So we get to see spikes in the DCI, and along with that a distal latency of less than 4.5 centimeter. This is 4.5 seconds. This is important. Now when you talk about the management of diffuse esophageal spasm, you have to understand that the first line is always conservative, and when we talk about the conservative, we have to go for, most of the time stress is a big factor to aggravate these things. So we go for tricyclic antidepressants. Along with that you can go for calcium channel blockers. These are the standard. Remember, if it fails, if the symptom worsens, if they don't respond, yes, then you will have to do a long segment esophageal myotomy. Is that clear or no? So that will reduce the contractions strength. So long segment esophageal myotomy, this is what is the treatment that we require if it fails to respond to the conventional, you can say, conventional therapy. Second is, let us talk about the nutcracker esophagus. The term was given by code. So nutcracker or a jackhammer esophagus. When we talk about jackhammer or nutcracker, or in case the third is hypercontractile esophagus. What is a classical difference? It is like, so you must have encountered across one of your friend. So he's a gym enthusiast, and whenever you go to meet him, he shakes his hand normally, but you feel it quite painful. Why is this so? The answer is, his handshake is normal, or he might pat on your back. Hi friend, hi dear, how are you doing? So everything seems to be normal, but actually his shoulders, his arms, everything is so strengthy that it feels that even normal pat is just like you are getting scolded by him. So that is the same scenario happening here. There is no problem. However, there is increase in the musculature, there is increased muscle strength, and along with that by terms of hypertrophy. So there is trophy of the, you can say, inner circular muscles and outer longitudinal muscles, and that is going to result in increased contraction power. So on manometry, if you see on manometry, and you should remember that in fact this is the most common spastic disorder. So when you go for the manometry, you get to see one very strange thing. What is that? Normal peristaltic waves. So normal peristalsis. So when there is normal peristalsis and problem, where is the problem? With abnormal contraction amplitudes. Is this clear? No. So increased contraction amplitudes, this is actually responsible, and usually it is more than 400 to 500 mmHg. So basically on manometry you get to see this, and what is represented here, the IRP is absolutely normal, so therefore lower esophageal sphincter is absolutely normal. The second thing is distal latency is more than 4.5 seconds, so therefore there is no spasm. But then why it is painful? It is painful because the contractions are, you can say, generating that. So this is just like a nut. When you get it in between, in a nut cracker, the same clasping pain that you feel at the level which is around the esophagus. Remember, distal contractile integral. I have already told you the DCIs represent the strength of the esophagus. So distal contractile integral of this case is more than 8000 mmHg second centimeter, and this is where the problem is. Everything is normal, and therefore when you talk about the management in detail, if you go to the Dadagiri series 1, I've talked about it, that okay, this is male to female is 1:1, and there are certain stressors like caffeine is there, peppermint is there, or spicy food is there, which can actually provoke this. So we need to avoid all these things. But the management is lifestyle modification. This is avoid, you can say, stressors. Along with that, if you require at all plus minus calcium channel blockers or nitrates, you might even go for nitrates in certain cases. Might be useful, might not be. If that doesn't work, then only thing is that you go for surgery, which is not required. Remember the first line, and this is also equal to the treatment of choice, and this is conservative. And remember, this is or along with that tricyclic antidepressants. If it doesn't work, yes, you will have to go for a Heller's myotomy. Is this clear or no? And the aim is, yes, when we do a myotomy, we reduce the strength. So basically, hypercontractile esophagus is nothing but a normal esophagus going to a gym. The third thing that we get to see is hypertensive lower esophageal sphincter. We have already seen why it is hypertensive. Now, how to understand this and how to differentiate HLES with achalasia. Here, integrated relaxation pressure on manometry, what do you get to see? So I'll explain in a basic language also, and I'll explain in the manometric values also. So on manometry, the peristalsis is absolutely normal. So this is normal. Then what is the problem? The problem is the lower esophageal sphincter resting pressure. The pressure of this is usually more than 40 to 45 mmHg. What is the normal resting pressure? This is important. So if you talk about the normal resting pressure in case of any, you can say, lower esophageal sphincter, if you see, it is 6 to 25, or you can say 6 mmHg to 30 mmHg, and the average is 25 mmHg. So here if you are seeing, it is more than 40 to 45. Remember, on manometry, the DCI is more than 450 up or and less than 8,000. So you can understand that this is not a abnormally increased strength of the esophagus. The problem is IRP, integrated relaxation pressure. This is more than 15 mmHg. The distal latency is more than 4.5 seconds. So there is no spasm related pain. So everything is totally different. You have to see with the different, you can say, specs. The next very interesting thing is that, sir, this is the same which is happening in achalasia also. So how is it different from achalasia? Try to understand. In achalasia, hypertensive LES, this is present. Yes, this is present. When we talk about the peristalsis, so this is proper in HLES. This is absent here. Is that clear? And this is the very important thing. So therefore, if you see the DCI in case of achalasia is less than 100, and here it is more than 450. The second is integrated relaxation pressure. Here is high, and this is how you differentiate lot of things. When we talk about the distal latency, here it is more than 4.5 seconds. Here it is either you can say normal or decrease in case of vigorous achalasia. So this is how you do. Remember, when manometry was not that strong, there was something which was known as Macaulay deinnervation sensitivity test. We shall see it. Just wait. I'll go to now achalasia and explain you each and everything in detail about achalasia. So let us understand that also. I've already told you, when we talk about inefficient esophageal motility disorder, what are the things that we can see in inefficient motility disorder and how should we approach it? Remember, recurrent GERD, this is the reason why the things worsen. So whenever there is recurrence of reflux, this reflux is going to form acid will cause damage, and damage will cause permanent esophagitis with fibrosis. So this is very important. So fibrosis or fibrotic zone above the lower esophageal sphincter is something like a natural speed brake. So the esophageal peristalsis is going down a normal esophageal wall, but all of a sudden the lower 3-4 centimeter becomes peristaltically you can say very difficult. Why? Because it is fibrosed, and this is what is known as inefficient esophageal motility disorder. So what is happening here? So this is classically associated with GERD, long-standing esophagitis. It may be associated with scleroderma. These are the classical things, or it may be associated with epiphrenic diverticulosis. So what is happening? Everything is okay on manometry. What are we going to get? Because peristalsis is not there. So distal contractile integral, if you see, this is low. Along with that, normal integrated relaxation pressure. So if you see low DCI with with increased IRP, it becomes achalasia. Here everything is not okay. So the distal latency, this is also absolutely normal. The contraction deceleration point, this becomes abnormal. So this is more proximal. Why? Because that is the time when the esophageal peristalsis stops. Normally it is 2 centimeter, here it may be 5 centimeter. So yes, there is an abnormal CDP, there may be low DCI and normal IRP. Dear students, why I have taken this esophageal motility and manometry concepts? Because none of the apps are explaining this fact, and majority of the time the students are stuck remembering anything like okay, dysphagia, dysphonia. These are useless. The only way to understand the motility disorder is with the help of the manometry. Now let us understand the concept of achalasia. So when we talk about achalasia, what are the things that we need to understand? Achalasia is an autoimmune disorder nowadays. It has been declared autoimmune. So what are the classical associations? It may be autoimmune. Remember why? It has been seen to be associated with increased CD8 count, or it may be idiopathic. It may be associated with corrosive injuries. It may be associated with some neurodegenerative cases, conditions, or it may be it may be associated with trypanosoma cruzi. So that is Chagas disease. All these things you know. Let us understand the concept of achalasia, the pathophysiology of achalasia. So achalasia, always remember, is a what diagnosis? It's a diagnosis of manometry. Because again the presentation here will be dysphagia. Dysphagia with reflex. So the classical presentation that we have is dysphagia plus reflux, and along with that plus minus there may be some pain also, and this is only seen in case of vigorous achalasia. So you know that there are three types: type 1, type 2, type 3, according to the classical Chicago's classification. Now when we are talking about the pathophysiology, let us understand 2-3 things. So this is the esophagus. In order to have effective peristalsis, there has to be regular contraction relaxations, and to maintain this contraction and relaxation we have two forces which are working. So what are the factors causing relaxation? So there is something which is causing relaxation, and there is something which is causing contractions. So contractions of the esophagus, so you can say inhibitory and excitatory reflex, or you can say ganglions. So this is inhibitory ganglions, and when we talk about inhibitory ganglions, they are basically submucosal orbex and manometric. So Meissner's and manometric plexus. So we have submucosal, Meissner's and manometric plexus. So this is very interesting. So submucosal, Meissner's and manometric plexus. So these are the classical inhibitory ganglions. And when we talk about excitatory, they are the one which are causing what? The, you can say, contractions. So this is acetylcholine ganglions. One more thing which is helping in relaxation is the NOS, nitric oxide synthetase. Now dear students, what is happening in case of, you can say, achalasia? In achalasia, there is very interesting phenomena which is happening. There is slow plus progressive. So slow and progressive loss of Meissner's and manometric plexus. So Meissner's and manometric plexus, the moment they are lost, and therefore there is loss of the relaxation. Now you will say, I'm not worried about this fact because there is loss of relaxation, because NOS is there, nitric oxide synthetase is there. There is one more thing which is happening, is there is abnormal and non-functional. So abnormal plus non-functional nitrous oxide synthetase enzymes. So when the INOS, endothelial NOS, is not working, and the inhibitory ganglions like Meissner's and manometric plexus are not working, so therefore all these things, therefore there is unopposed what, students? Contraction. And when there is unopposed contraction, what is the thing that is going to happen? Since it starts usually at the level of lower esophageal sphincter, so on manometry, the first thing that you get to see is that the acetylcholine is acting maximally at this level. So the early phase, on the early phase at lower esophageal sphincter, you see increase tone at LES. This is first thing. And along with that, it fails to relax because relaxation is lost. So increased tone at the level of LES. Along with that, there is failed relaxation. So there is failed relaxation here. Apart from that, dear students, one more thing is that slowly at the level of esophagus, at the level of esophageal body, what you get to see, the peristalsis is lost. So there is a peristalsis, very interesting. So loss of tone and along with that a peristalsis is there. Along with that, slowly and slowly there will be low amplitude waves. So even if the waves are generated, so there will be low amplitude waves. You know that why this is happening, because there is nothing known as the synchronology between the excitatory and the inhibitory ganglions. And slowly what is going to happen, the contractions along the esophageal body will cause increase in pressure across the body, and therefore there will be pan-esophageal increase pressure. This is again very important. So pan-esophageal increase pressure is going to happen here, and this is what is the classic manometric diagnostic criteria. Is this clear or no? So based on this, achalasia is of 3 types. So this is a mini marathon. I just need to revise and let us see what is the Chicago's classification. So when we talk about Chicago's classification, what are the types? The type 1 achalasia, this is a classic type of achalasia. What do you get to see? You get to see hypertensive LES, lower esophageal sphincter. Along with that, it fails to relax. So failure to relax, this is second important point. And along with that, you get to see a peristalsis. This is one very interesting thing. Type 2 is the type where you get to see hypertensive LES, along with that failure to relax, and along with that you get to see a peristalsis. Then what is the difference? Along with that you get to see pan-esophageal increase pressure. Are you getting this point? So pan-esophageal increase pressure, and this is what is type 2. Do you know that type 2 is the one which shows best prognosis? So best prognosis to pneumatic dilatation. Pneumatic dilatation is shown by, you can say, type 2. When we talk about third, now this is very interesting. This is what is known as vigorous achalasia. So this is known as vigorous achalasia or painful achalasia. Now what do you mean by this vigorous achalasia? This is nothing but it is simultaneous and simultaneous spastic mirrored contraction. So now what happens when the type 1 starts and it progresses to type 2? There is a phase when the esophagus itself revolts that I will generate peristalsis and I will try to cross this LES. Now what happens? It generates peristalsis, but unfortunately the simultaneous mirrored contraction, and that is why, and therefore this is the one where you get to see increased DCI with low distal latency on manometry. Here what do you get to see in others? We get to see elevated IRP, along with that normal distal latency, along with that we get to see low distal contractile integral, and along with that pan-esophageal pressure more than 30 mmHg. Is this clear or no? Usually what is the normal pressure of the body during contraction? 20. If it is more than 30, this is what we get to see. And type 1 is we get to see increase IRP, and along with that low, you can say, low distal contractile integral. Is this clear to everyone? And this is how we classify the 3 different types of achalasia. Type 1 and type 3, they are the ideal candidates for surgery, and type 2 is the ideal candidate for botulinum or pneumatic dilatation. This is the simplest way to understand achalasia or any motility disorder, because if you don't understand the concept of IRP or DCI or distal latency or contraction deceleration point, you'll never be able to go forward. Already I have covered this topic in detail and in depth in the, you can say, in my routine lectures, but the objective of taking this topic today was just to revise the manometric association again. When we talk about the management of achalasia, so every day I would be picking up some part of, you can say, surgery, and you can say trying to dissect some tough part and discussing it. So when you talk about the management of achalasia, the first line is always conservative, but remember this conservative management will fail. And what is that? It is nitrates. So nitrates, or you can say, so basically 5 mg isosorbide, and this is taken almost 10 minutes prior to meal. 10 minutes prior to meal. But the problem with this is, the side effect is headache, and not only headaches, it is tachyphylaxis. So headaches plus tachyphylaxis. Slowly and slowly you will see that higher dose is required to produce the same effect. So this is one. Then we have phosphodiesterase inhibitors. So this is again very interesting, pentoxyphylline. Basically we are taking pentoxyphylline, or we can take others also, sildenafil, etc. So 400 mg, we can always take it twice or BD or TDS. The third that we have is calcium channel blockers. So basically nifedipine is what is the agent that we take. 10 mg to 30 mg is what we take, and at least 30 to 45 minutes prior to meal. This is how we actually take. Unfortunately, the medical management never responds. So when the medical management actually fails, then in that case you have to go for intervention. Now the first line intervention, that we talk about are the, you can say, classical endoscopic interventions. Now when you talk about the endoscopic interventions, what is a classical endoscopic intervention that we do? The first option, the first line, it could be injection botulinum. So when we talk about injection botulinum, the most important concept that it has is it will block the, you can say, acetylcholinesterase inhibitors. It will mask that area. But there is a problem of fibrosis of the lower esophageal segment of the esophagus, and in future it might be more aggravating in nature. Reversal is the most popular endoscopic management is pneumatic dilatation. Now this is very important. So pneumatic dilatation, and remember it is ideal for type 2 achalasias. So for type 2 achalasias it is ideal. The classical pneumatic balloon that we take is Rigiflex, and it is available in 3 diameters. It is 30 mm or 35 mm or maybe 40 mm. So this is the classical sizes that we have. Now there is a controversy of serial versus single dilatation. Let me tell you, when we talk about serial dilatation, they have, when we talk about 6-year data, 40 to 26% you can say symptomatic relief. So if you do a serial, you can say, dilatation after 6 years, 46% still have relief, and only 26% will have relief after, you can say, 6 years. So yes, serial dilatation, remember they are dilated and dilated for 15 to 30 seconds only. So this is important. So 15 to 30 seconds I am saying. So 15 to 30 seconds. Remember, dilatation is done in series. What could be a classical drawback? The classical drawback that we have is endoscopic esophageal perforation. So esophageal perforation is the cause of controversy. Remember, when we are talking about the dilatation, what we are going to do? We are going to cause controlled tears over the inner circular muscles. This is what is happening. So the aim of the pneumatic dilatation, the aim is controlled tears along the inner circular muscles. Now the next very interesting thing is, the last is, if all these interventions fails, if this fails, then we have option of POEM. So per oral endoscopic myometry. So this is A poem, that is for achalasia, and we can also go for Heller's myotomy. So Heller's myotomy, remember, if Heller's myotomy and poem both of them fails, yes, we will go for the transhiatal esophagectomy. So since this is a revision class, I will not go into further details of what about the surgery and each and everything. Remember, I will tell you 2-3 basic points about this, and the most important thing that we have to understand is about pneumatic dilatation. One more thing is that pneumatic dilatation have high success rate. So high success rate of pneumatic dilatation is seen in patients with age more than 45 years, point number 1. So older patients. Second is females have high success rate. The third is narrow esophagus. Of course, that's a common sense. So narrow esophagus, females age more than, and remember, decrease in, you can say, pressure, decrease in pressure of lower esophageal sphincter up to 10 mm Hg, up to 10 mm Hg post dilatation. So these are the patients who are actually responding and have a favorable outcome. When you talk about poem versus Heller's myotomy, we need to understand, we divide the inner circular and outer longitudinal muscles, both are divided. Now there are 2-3 questions asked in Heller's myotomy. So we do a modified Heller's myotomy, and modified Heller's myotomy has a small extent. And what is that small extent? Let us see. So modified Heller's is 5 to 7 centimeter above G junction, 2 to 3 centimeter below G junction. This is important. So 5 to and 2 to 3 centimeter below the G junction. Just a minute. 2 to 3 centimeter below the G junction. What is ideal Heller's? What is along with that you have to do a partial fundoplication. So if you want to, you can say, go through and revise this concept, yes, you can go to my routine lectures in Dadagiri series 1, where I have described these things in detail. What is ideal Heller's? Post surgery, the pressure should decrease by more than, the pressure should decrease by more than 10 mm Hg. So if you have done a successful Heller's, the resting pressure should decrease by 10 mm Hg. This is about the concept of esophageal motility disorder. I hope you enjoyed. Every day we will be taking the classes. However, up till 19 I will be taking, because on 20th I am going to Malaysia. So if you are watching this video from Malaysia, yes, I am coming to Malaysia for laparoscopic intense hands-on training program, and the details are there on my website, and the details are also shared on the groups also. So if you are a Malaysian students, do join us for the laparoscopic hands-on training program. And a salute to all the surgeons, all the residents who have newly joined the department, and to all the surgery enthusiasts. That Surgery Dada is growing massively. We have expanded almost to 27 plus countries, and it's a matter of proud that it's the fastest growing surgery community. We mean real surgery, nothing shit. Real surgery in terms of, this is the only platform which teaches surgery, which upskills you, which trains you in surgery. So what are you waiting for? If you have not, you can say, subscribe to us. If you have not, you can say, purchase any program, do join us, be a part, and explore the vast, you can say, scenarios that we can create for you. And do recommend Surgery Dada to everyone you meet. Till then, bye bye. We connect again tomorrow at 8:30, right at this time, Indian Standard Time, 8:30.